Good morning, everybody. Today's topic is surgeon's perspective in liver transplantation for pediatric inborn errors of metabolism. The topic itself is a class for me to go through all these inborn errors of metabolism, but I will try to restrict it what are the surgeon's perspective and a short visit to the different indications for liver transplantation in this group of patients. So I will go through introduction, classification of the different errors, important IEM for liver transplantation, surgical aspects, a role of LDLT and donor evaluation, and two unique transplant concept of auxiliary partial, orthotopic liver transplant and domino liver transplant. So inborn errors of metabolism are rare, inherited genetic disorders occurring in roughly 1 in 2,500 births. Defects in the proteins or enzymes prevent the body from properly converting food into energy, leading to accumulation of toxins. Inborn errors of metabolism remains the standard term, but other terms which are interchangeably used for this specific subtypes are inherited metabolic diseases, congenital metabolic diseases, and enzymopathies where a single enzyme is defective and leads to the pathological consequences. Liver transplantation is, as all of us know, is the gold standard for the treatment of end-stage liver disease. Select patients of HCC and ALF. In patients with inborn errors of metabolism, a genetically normal liver can correct the defect by providing a lifelong enzyme replacement therapy. LTX is liver transplant now established therapeutic approach in these patients, but there are many dynamic changes associated with. Definitely, it improves the patient's metabolic control and disease burden, reducing the frequency of metabolic crisis and halts the neurological damage. The results of transplants are comparable with those with other indications of transplants in this pediatric age group. This published in the split registry data. So again, showing the different indications of liver transplant in pediatric patient as per the split registry data, and it is second common indication for liver transplantation followed by biliary atresia. Apart from that, almost 30 to 35% cases of pediatric ALF have underlying inborn error of metabolism, and the current 1 year patient survival rate almost exceeds 95% in these children, including all types, DDLT, LDLT, and other indications. But this is not that straightforward. There are definite challenges when we evaluate or undertake a child with inborn error of metabolism for transplant. First is the heterogeneity inherent in these disorders, the way they present, limited to liver with extrahepatic manifestation, the impact of liver transplantation on the disease progress, whether there is recovery from the neurological complication, they will progress or they will remain like that. Then the precise timing of LT, when to perform it, when the child is too small or late, if you are performing it late, is it too late, or more importantly, before the manifestation of neurological disabilities. And this is all related to complex natural disease trajectory. And another thing is quality of life, because before transplant also, the quality of life is poor, and some people criticize it that a patient of inborn error of metabolism is just remains the patient because the disease is changed. And again, the need for lifelong immunosuppression and its consequences, especially when the liver is normal and there is single enzyme defect, and obviously the post-LT outcomes. So I visited this and there are almost 1,400 metabolic disorders which are classified, and it's very difficult, and it's definitely a multidisciplinary approach, and you need a pediatrician to help you before you take any decision. So coming to the classification, which is very close to our interest, we can divide whether the liver is normal or not normal, and whether there are extrahepatic manifestations or no extrahepatic manifestation. So this simplified classification, first we go that there is a structural liver disease, and that is confined to the liver. The liver has developed cirrhosis, HCC, or present as other patients like decompensated liver disease, or occasionally like acute liver failure. The common one are the alpha-1 antitrypsin deficiency. Next comes Wilson's disease and hereditary hemochromatosis. When there is structural liver disease with extrahepatic manifestation, then again the ball changes, because what we are going to offer. Then it comes the Alagille syndrome, cystic fibrosis, Niemann-Pick type C, mitochondrial hepatopathies, and telomerase biology disorders. Practically for a surgeon, it's very difficult for me to understand all this at present, but I try to simplify. On the right side, there is absence of structural liver disease with enzyme deficiency confined to the liver. This is a very important group, because many proponents suggest that 15 to 20% of a normal liver activity is sufficient to correct the enzyme deficiency. When the enzyme deficiency is, or the problem is limited or confined to the liver. Typical are Crigler-Najjar syndrome, familial homozygous hypercholesterolemia, and urea cycle defects. Then the next is absence of structural disease with extrahepatic manifestation. This primary hyperoxaluria. Again, it changes the perspective, because the role of simultaneous kidney transplantation comes in. Then the MSUD, maple syrup urine disease, and this organic acidemias, MMA. So again, practically, whether a patient should go for a partial APOLT or a standard OLT, or a patient, or whether the patient will benefit with liver transplant, there's again a surgical classification, and which takes that type 1 cirrhotic MLD, metabolic defect, causes direct hepatocellular damage leading to fibrosis, cirrhosis, portal hypertension, and HCC. Wilson's, tyrosinemia type 1, hemochromatosis, alpha-1 antitrypsin deficiency, and glycogen storage disease. Type 2 is non-cirrhotic MLD, liver-only principal site of gene expression. Native liver is structurally normal apart from the single enzyme defect. Less than 20% normal activity is usually enough to correct phenotype, and this includes the Crigler-Najjar, urea cycle disorders, FAP, primary hyperoxaluria type 1, then hypercholesterolemia, hyperoxaluria type 1, hemophilia, atypical hemolytic uremic syndrome. Type 3, non-cirrhotic metabolic liver disease, system enzyme, defective enzyme expressed in multiple organs, liver one of them. Liver transplantation ameliorates but does not cure the systemic disease. These are the propionic aciduria, maple syrup urine disease, methylmalonic acidemia, and homocystinuria. Please pardon me, I'm trying to simplify it for myself. And yeah. So coming to the individual disorders, if we take first is alpha-1 antitrypsin, because it is either autosomal recessive or considered as codominant disorder caused by a mutation in SERPINA gene. It is one of the commonest IM requiring liver transplant because the either end-stage liver disease or ALF. But to a surprise, almost 0.8% of the presumed healthy livers are heterozygous for this deficiency. But the landscape is again changing. What is important in this disorders, that fagocitrin and RNA interferase therapeutic in adult with this disorder have showed promising results and may change the or alter the indication for liver transplant in this group of disorder. Wilson disease, we recently have a single theme conference, so it's I can just take one slide because it's an extensive topic. It's a progressive copper overload disorder due to mutations in the ATP7B gene encoding a copper transporting P-type ATPase. Liver transplantation, there is a consensus that either a decompensated CLD or a fulminant liver failure. After liver transplant, lifelong normal copper metabolism is restored. The cumulative survival rate is 90%. Potential heterozygous donors should have serum ceruloplasmin and urinary copper levels measured because it's an autosomal recessive. And potential donors with high urinary copper levels are ideally to be excluded because they might be the cases in the pre-symptomatic phase. Coming to the urea cycle defects, this is again a group of disorders. Recurrent life-threatening episodes of hyperammonemia. LT is life-saving therapy that functionally abolishes the metabolic defect and transfers quality of life. LDLT is equal outcomes and restores the normal dietary tolerance and metabolic symptoms. LT had a limited effect on controlling the neurodevelopment outcome in these patients with severe disease because hyperammonemia at the onset time already had a significant impact on the brain, and excellent results observed in this disorder. In this disorder, except ornithine transcarbamylase deficiency. This is from the data, Japanese registry data with the longest series, and most of the patients were LDLTs. And the second disorder, which they have described, that doesn't have those attractive results or impressive results after liver transplantation, and that is OTCD. And this is one of the longest series retrospective data of 20 patients of OTCD. 6 had neonatal and 14 had late onset presentations. Almost 75% patients had neurodevelopmental problems. The indications for transplant were recurrent metabolic decompensations, neurodisability, and quality of life impairment. Median age in the early onset was 10.5 and late was 66 months. Overall survival was 95% with 2 required retransplantation. The patients remain metabolically stable, but the neurodevelopment problem persists. Though it doesn't worsen, but it doesn't recover also. That's the drawback. And here, the role whether we should offer transplant. Another is problem with this disorder. It is X-linked, and we have to be careful when we evaluate the parental donors for this, or may opt for an excuse from a first-degree relative for LDLT. Then again comes the maple syrup urine disease. Is an organic acidemia caused by deficiency of branch chain keto acid dehydrogenase enzyme complex, neurotoxicity due to accumulation of branch chain amino acid. This is a systemic enzyme expressed other than liver in skeletal muscles, brain, and kidney. Liver transplant replaces only a small percentage of the total amount of enzyme in the body, but again it appears to be curative. Heterozygous donor might not supply sufficient enzyme replacement, and MSUD livers are actually a logical source for domino liver transplants. Coming to tyrosinemia type 1, deficiency of fumarate acetoacetate hydrolase, neonatal hepatic failure, late onset CLD, very high risk, lifelong risk of development of hepatocellular carcinoma. But early treatment with NTBC has revolutionized management. The current indication for liver transplants are late diagnosis, unresponsive liver failure, development of HCC, and if NTPC is not available. Crigler-Najjar syndrome, again uridine diphosphate gluconosyl transferase deficiency, severe unconjugated hyperbilirubinemia with neurological damage and kernicterus. Intensive phototherapy almost 24 hours per day is the mainstay of the treatment. LT provides a functional cure and should be planned before irreversible neurological changes developed. All LDLT, then auxiliary liver transplant, and DDLT have shown good outcome and lifelong freedom from need for phototherapy. Primary hyperoxaluria type 1, the defect in the liver but affects the kidneys. Deficiencies of hepatic alanine glycoxylate, aminotransferase, oxalate overproduction with nephrocalcinosis, renal calculi leading to renal failure. Oxalate is only renally excreted, and as renal injury progresses, oxalate accumulates, resulting in systemic oxalosis with cardiac, ocular, and bone marrow involvement. Usually isolated liver transplant is preferred in the LDLT setting when GFR is around 40 to 50, but SLK is mandatory when GFR falls below 30. Sequential transplantation may be preferred in case of living donor, except in cadaveric. If the child is getting a cadaveric liver, it's better to do the SLK than going for a sequential. Heterozygous carriers in the living donor setting have been used successfully as liver kidney and liver kidney donors with similar metabolic correction as seen in cadaveric transplant. Glycogen storage disease, it's a very complex phenomenon and a vast classification, but a group of disorders characterized by hepatomegaly, hypoglycemia, and occasionally cause progressive liver failure. Usual indications for liver transplant include poor metabolic control, progressive liver disease, hepatic adenoma, or carcinoma. The hepatic metabolic derangements are reversed by liver transplant with improved growth and quality of life on unrestricted diets. Many reports have shown that LDLT is safe and efficacious in glycogen storage disease with comparable results. Extrahepatic complications are not impacted by donor type and similar, but there is a doubt how much of them revert. Organic acidemias, this is the systemic accumulation of toxic intermediary metabolites, including methylmalonic acidemia and propionic acidemia. MMA, deficiency of methylmalonyl coenzyme mutase. Then propionic acidemia is a deficiency of propionyl carboxylase. Clinical presentations, neurological, may progress to coma and death, recurrent metabolic crisis, poor growth, and impaired neurodevelopment. Transplant provides an important partial phenotypic correction, permitting relaxation of dietary restrictions, significantly reducing the risk of ketoacidosis and improving quality of life. But extrahepatic complications, including renal failure and metabolic stroke, persist, and the data is unclear that how much success can be achieved. Homozygous familial hypercholesterolemia. Homozygous is devastating condition resulting in cardiovascular death by second decade, which does not respond to lipid-lowering treatment. LT, which reduces cholesterol by 80%. The long-term cardiovascular outlook again for these recipients is not clear. Expanding non-transplant options for this disorder, the use of heterozygous donor can be justified only where there is no other donor available, because it may not achieve the goal. So this is a summary of indication, disease, and when to offer transplantation. So usually these are the prevent or reduce risk of metabolic decompensation, improve metabolic control, prevent, reduce, or organ transplant complications, improve long-term neurological outcomes, improve growth, improve disease burden, quality of life, prevent ALF or recurrent acute liver injuries, treat end-stage liver disease, treat liver cancer, attempt to treat an unsuitable disease selected cases. Only most of the cases, to summarize, that warrant early liver transplant so that the neurological complications can be prevented. Only when the diagnosis is late or there is development of HCC, late liver transplantation can be considered. So coming to LDLT is an increasingly being performed. Careful donor evaluation is important. Most inborn errors of metabolism have autosomal recessive traits. Living donors are generally blood relatives who are obligate heterozygous carriers of the disease. Pose the potential risk of the donor graft having inadequate metabolic function, preoperative genetic assays, and parental donors with HLA homozygosity needs to be addressed. This is the relative risk of using graft from parental donors. First comes the ornithine OTCD, that is X-linked, 1 in 17 to 18,000 birth. Marginal parental donors is the heterozygous mother, and the risk is the persistent of hyperammonemia. Then protein C deficiency, again heterozygous parents, thromboembolic events after transplant. Then familial hypercholesterolemia, which is homozygous, then a heterozygous parent may not correct the deficiency completely. Acute intermittent porphyria, autosomal recessive, heterozygous relative, decrease in porphobilinogen deaminase activity. Then erythropoietic protoporphyria, again the heterozygous relative, there is a decrease in the activity of the enzyme replace. Alligali syndrome, this is asymptomatic, but there might be some biliary changes, and the MRCP is mandatory before taking a graft from here, because there is a risk of cholestasis after transplant. Hepatorenal fibrocystic disease, and all living donors, it's better to go for a HLA matching because homozygosity is associated with graft versus host disease. So the donor evaluation protocol, as we follow in the first part, second part, specific to the disorder, urea cycle disorder, genetic analysis to exclude heterozygous OTCD mother. Then congenital deficiency of protein C to exclude the heterozygous donors. Same for familial hypercholesterolemia, porphyria, Allegany syndrome assessment, particularly of the MRCP or liver biopsy and genetic analysis of asymptomatic donors. Again, hepatorenal fibrocystic disease, same to rule out multiple liver cysts and determine whether they are connected to the bile ducts. Wilson's, organic acidemia, alpha-1 antitrypsin deficiency, Crigler-Najjar, primary hyperoxaluria, or maple syrup urine disease does not require additional evaluation. So coming to the truly surgical perspective about the recipient operation, liver transplantation in patients with metabolic disease, especially in which the liver is essentially structurally normal, then there are specific issues because the liver is not cirrhotic, there is no ascites, there is no, the abdominal cavity has almost normal dimensions and there is no portal hypertension particularly. So these patients do not tolerate portal or systematic clamping as a patient of CLD will do. And so that's why we have to keep the clamping time at as low as possible to prevent the intestinal congestion and hemodynamic stability. Then in case of metabolic diseases, the donor-recipient dimensional matching is more important because small children and they don't have portal hypertension, there is no hepatomegaly. And so we have to not only just the graft to recipient weight ratio, but we have to be more restricted to avoid the large forsyth syndrome, which increases the vascular complications and primary non-function or early allograft dysfunction. Neonatal LF is another challenge. The available space is really low and reduction or hyperreduction techniques or monosegment transplant techniques to be followed. In case of DDLT, the donor characteristic and ischemia times must be so adjusted so that there is a prompt functional recovery of transplant organ to reduce the risk of acute metabolic decompensation. It is like liver not working, but that may manifest as the acute metabolic dysfunction that has to be kept in mind. Perfusion machines or normothermic machine perfusion can help in this, but data is still upcoming. Coming to the interesting part or type of transplant, that is auxiliary partial orthotopic liver transplantation. In this, a part of the liver, usually a left hepatectomy performed in the recipient, and a left-sided graft is implanted in the same area. It's an advanced LT technique in which segmental or sectoral graft is implanted into the orthotopic position while preserving a portion of the native liver. In the context of ALF, APOLT has been described, and the purpose is that if the native liver regenerates, then the need for lifelong immunosuppression can be avoided. It was typically described in patients with paracetamol or viral hepatitis. But children with, why to do it in children with non-cirrhotic metabolic liver disease? Because this partial graft is sufficient for the metabolic correction while preserving the native liver for future therapies, because it's just a bridge to the future, what the authors have described. Because if any gene therapy or pharmacological therapy becomes available or a hepatocyte transplant becomes available, then the patient can be cured with his native liver and the immunosuppression can be stopped. So the unique problem associated with this APOLT is the portal steal phenomenon that may lead to the graft atrophy, and the pioneers have described this three-level technique. First, that is called graded hemiportal banding in left lobe APOLT. First, the portal pressure being measured in the remnant liver after left hepatectomy, that is the right liver. P2 after implantation of the graft in the main portal liver. Flow to the nerve. This should be less than P1. P3 is the portal pressure in the graft is measured after clamping the portal venous pressure of the right lobe. In patient with non-cirrhotic MLD, the graft portal pressure may be higher. In these cases, a graded banding of the remnant liver is performed until the portal pressure of the remnant is higher than that of the graft. Because if the pressure on the remnant liver or the native liver remains on the higher side, there will be portal steal and the graft will get atrophic. And the problem with this is that if the graft gets atrophic, the problem, it doesn't manifest with any derangement of LFT, but the purpose for which the metabolic derangements will not get cured. Similarly, arterial reconstruction, there is a disconnection, actually anatomical disconnection between the right lobe and left lobe to make it simple, so that again there is no steal phenomenon and the graft is maintained individually. So another interesting concept is the domino transplant for pediatric liver recipients. This involves 3 consecutive but at the same time overlapping operation. In explanted liver from deceased donor has approximately 15% normal enzyme activity is enough for MSUD patients. Explanted enzyme deficiency liver from MSUD patient is compensated by approximately 85% normal extrahepatic enzyme activity in domino recipients. Though this is not exactly as for the benefit of these patients, but the MSUD grafts can be used as domino for benefit of other patients. So this is the summary of the diseases in which domino transplantation has been attempted. First is, all of us know, is FAP, familial amyloidotic polyneuropathy. Then the MSUD, as I have just described. Then familial hypercholesterolemia, primary hyperoxaluria, MMA, propionic aciduria, ornithine transcarboxylase deficiency, and Crigler-Najjar syndrome. So domino and auxiliary. This is another interesting case which recently has been first described in 2017. Then a series has been described that domino and auxiliary transplantation can be used together. The 2 domino grafts with different metabolic liver disease could compensate for each other's metabolic defect. A domino graft from a child with Wilson's disease and a second graft from a child with OTC deficiency were successively implanted into an adult woman with FAP, and the authors reported almost a 4-year follow-up asymptomatic. Then domino cross-auxiliary using non-cirrhotic metabolic graft for auxiliary transplantation in other patients with an alternative type of metabolic disease. 2 partial livers are exchanged or swapped between 2 patients with different non-cirrhotic metabolic disease. In this way, LTX can be performed without a healthy living donor or a deceased donor. And this is unidirectional, means that liver with the systemic metabolic disease used as the donor graft should be transplanted to a recipient with a single liver metabolic disease and not for cirrhotics. Then this is the technique, surgical procedure, and the refinement of implantation of the domino graft. First is the left lobe with MHV recipient, common trunk as usually done in the left lobe liver transplantation, but here the complexity increases because the right-sided liver is still there. Then the second is the portal vein implantation. Usually it is a separate implantation in the main portal vein. Then there is the arterial disconnection and the implantation of the left hepatic and a Roux-en-Y hepaticojejunostomy for the ductal reconstruction. So this is a series of almost 6 patients who have undergone these patients and received this auxiliary domino cases, and they have reported survival with some problems, only 1 death because of a surgical issue. And another interesting case, what I brought to, because though it's a case report, but it's a lot of science in this, the metabolic chimera into defective genotype, making a normal phenotype. First patient with a PA O positive, second patient Crigler-Najjar syndrome A positive. First patient underwent APOLT and left hepatectomy was done, and mother was the donor. The left hepatectomy specimen of the first patient was implanted in patient 2 with Crigler-Najjar after performing a left hepatectomy and thereby completing the domino auxiliary transplant. Both the patients have uneventful recovery with no manifestation of either PA or with a normal ammonia. So this is Dr. Raila's publication long back, 2015, how a patient post-operative CT. This is domino graft deficiency in propionyl carboxylase, and this is the native liver with Crigler-Najjar, and both are compensating each other's enzyme defects. And this is the normal phenotype. To summarize, liver transplantation is the treatment of choice in children with inherited errors of metabolism. LDLT offers excellent outcomes. Careful liver donor selection is important. Experienced transplant surgeons in view of normal recipient livers without portal hypertension. Auxiliary partial liver transplant, technically demanding and considered bridge to the future. Domino liver transplant definitely increases the organ pool. Thank you.